Welcome Afoke, Arigbe and Caroline Cheo, who are clinical nurse specialists based in the adult haemoglobinopathy service at Imperial College Healthcare NHS Trust, and I'm particularly grateful to both of them for standing in at extremely short notice because the original speaker for today was not able to be with us, and by short notice I mean about 24 hours. So I think if we can give them a round of applause for and I'll hand over to Afoke and Caroline.
Don't think my microphone want me to talk. Good morning, everybody. Is it okay? Yeah, I need to get it fixed. It's coming. Yeah, it just fell. Better.
It might be better to take it on the other.
Okay. Sorry about that. Good morning, everybody. My name is Afoke Arigbe, likes to be called Afo, and my colleague.
I'm Caroline Cheo. Good morning,
I'm the little
Cheo.
sister, she's the big sister. Hi. So today we're just going to talk about management of acutely ill sickle cell patient, adult, as we're based in the adult setting in Hammersmith Hospital, Imperial College. I just want to say, bear with me, I'm very nervous. We do a lot of teaching sessions in Hammersmith, but we don't do big audience like this, so if you think I'm stepping out of line, please call me back in. Management of acute ill adult with sickle cell. We have different kind of pain and in sickle cell and medication that we use. So mild pain is just for the opioid naive patients, so we use non-opioid with a bit of adjuvant. Mild pain, we use weak opioid or low dose of opioid, and then we use adjuvant as well. And severe pains, we use strong opioid and adjuvant. Types of pain in sickle cell medication. For severe pain in Imperial, we use morphine, OxyContin, or oxycodone, fentanyl, PCA only. We do not use that morphine as it's been stopped in Hammersmith. PCA are mostly second line, and they are tailored by the consultant to suit the patient. In order to start PCA, we have to speak to the primary consultant as well to get an approval and also to get the dose. And then parental PCA in Hammersmith is given subcut, not IV. Other medications, we have paracetamol, ibuprofen, naproxen, ketamine we only use in ITU, pregabalin and gabapentin, and all patients must be prescribed naloxone for respiratory suppression, laxative, and also we have to put all our patients on prophylactic dose of Clexane. Apixaban we dose with Portacat because we use them mainly for our reset exchange due to the fact that some of them it's difficult to find events. So some patients have Portacat, and also for our antiemetic we use chlorpheniramine, cyclozine, and the rest. It is advisable because we are here we're presenting using the Hammersmith protocols, but it is advisable to check your trust guidelines and for and protocols for individual pains as well. So as we also use PCA, so for patients on PCA, we are advised to do a baseline observations before PCA can be started. So for temperature, for example, we have to do the temperature, blood pressure, pulse, respiratory rate, and oxygen sat. And for when the patient starts on PCA, for the first 2 to 6 hours, we have to do 30 minutes observation till the pain score is down by 2. In Hammersmith, we use 1 to 10 pain score, so we try to measure it by that. And for when the patient is on 7 hours till when the PCA is stopped, we do observations every 2 hours. And if the pain is not controlled and maybe the PCA is increased, we go back to the baseline again and we start from the top again. So immediate management of a vaco-occlusive crisis, analgesia within 30 minutes of arrival in hospital, commence observation chart and perform pain assessment using pain scoring tools, encourage oral fluid, but if patient cannot tolerate oral fluid, we can commence IV. Keeps patient warm and comfortable. Reassurance is key and very vital in this time for the patient. So aims for admission, with PROT assessments, need and diagnosis within 30 minutes of presenting, immediate admission for symptoms like severe pain crisis, increased pallor, signs of infection, acute chest syndrome, acute abnormality pain and distension, diarrhea and vomiting, and other neurological complications and practicing. When patients present in our A&E, it is advisable for them to contact us, the hematology team. Then we can give advice, show them where things are kept and where protocol, and also advise them if they need for admission. As our in Hammersmith, we do not have A&E in Hammersmith, so all our patients are present in both St. Mary's and Charing Cross, so they will have to transfer to us in Hammersmith where the adult team are. Also in A&E, also in Hammersmith, we have the upper acute unit called the RHTU, which is tailored for our hematology patient. Also, we share with the renal patient as well, so sometimes beds are not available, so patient will be diverted to A&E, but as I said, the A&E team work with us. Discuss with the team if admission is necessary when in A&E. Bloods needs to be checked, full blood count, electrophoresis, liver function, kidney functions, bone profile, CRP, group and save, and blood culture if infection is suspected. Encourage patient to drink fluid. If he's unable, start an IV fluid for the first 24 hours, then gradually reduce if they can tolerate oral. All patients should start on a prophylactic anticoagulant, for example, like tinzaparin and clexane, and dose for patient treatment, dose for patient with pulmonary emphysema, and admission, and also administer test stockings if patients are mobilizing. Other possible interventions would be red blood cell exchange and top-up transfusion and hydroxycarbamide. Caroline is going to do the next slide, and I will come back again.
Thank you. So infection in acute pain crisis. So sickle cell disease is associated with ill-defined immune defects due to being hyposplenic. Main causes will be pneumococcal, gram-negative, lower respiratory tract, urinary tract, osteomyelitis, and parvovirus. If patient's temperature is above 38 degrees, we usually start IV antibiotics. We normally follow the local trust guidelines and policy, and also the antimicrobial have to input on which antibiotics to start with, depending on the findings. Take a septic screen and order a baseline chest x-ray, discontinue prophylactic antibiotics and e.g. penicillin, patients who are already on penicillin V, or alternative antibiotics. Gain suitable venous access early to prevent infection developing into sickle crisis. Acute chest syndrome. The pathology is rapidly increasing red cell sequestration in peripheral pulmonary capillaries, interfering with gas exchange, causing hypoxia. Establish early diagnosis of acute chest syndrome by doing chest x-ray and blood gases, or pulmonary emboli. Early intervention improves recovery. Symptoms will be new infiltrates on chest x-ray, fever, chest pain. Patient would also have symptoms like hypoxia, with saturations below 92% or arterial blood gas below 8. Shallow breathing, semi-conscious, and with a GCS below between 12 to 14. So the management of acute chest syndrome will be blood gases as soon as possible and repeat frequently. Antibiotics, follow local trust guidelines and protocols. Incentive spirometer to the patients. For those who suffer from C2 retaining, we offer them CPAP. Transfusion therapy, exchange transfusion within 24 hours via femoral line or peripheral line, or we do deep cannulation for those who cannot have cannula inserted peripherally. Frequent oxygen saturations taken on air and then on oxygen therapy, give them oxygen therapy as well. Suitable pain management by following individualized patient analgesia protocol. Chronic pain management. So chronic pain usually in sickle cell is from bone damage, like avascular necrosis of bone joints. Management is usually with physiotherapy input. Weight, we encourage our patients to lose weight if they are overweight, or surgical intervention. Sometimes NSAIDs may help reduce inflammation and pain. Chronic nerve pain management, we may use pregabalin, gabapentin, and amitriptyline. Referral to the chronic pain team for more in-depth exploration. Consider orthopedic team for assessment and possible treatment. The psychological aspect. Patients often describe feeling of helplessness against the disease. They will say to you when we go on ward round, like you're partying in the morning and in the evening, you are in pain. So holistic approach to managing pain, both physical and emotional experience. Remember, patient has lived with sickle cell for many years. They need encouragement to try new things and change their perception of pain. Stress can be a precipitant of sickle cell disease. Empathy and understanding among staff members is paramount. Importance of social and community support is necessary. Consider referral to clinical psychology team for their input. Discharge information. Before discharge, provide the patient and/or their carer with information on how to continue to manage the current episode or preventive measures, to include how to obtain community and other specialist support. We usually contact their GPs to ask them if they can refer them to the various MDT teams in the community. How to obtain additional medication from the GP. How to manage any potential side effects of the treatment they have received in hospital. And how to prevent future illnesses, possible complications. In Hammersmith, the CNS do follow-up calls and they send a list of discharged patients to the community. And they have our contacts to contact us if they have any clinical questions. We encourage patients to take all recommended prevention, medication, and treatments, and also update their vaccination records.
So we just want to talk about no one is listening report. So this is Evans Nathan Smith. He's 21 years old from Waterstow, died in April 25th, 2019 in North Middlesex Hospital. He developed sepsis following a procedure to remove his gallbladder stone, and a week later, earlier. So he was 21 and he was diagnosed with sepsis, which was triggered by sickle cell crisis. So some of the reports says that we are concerned why patients with sickle cell conditions should be nursed on a ward where nurses are not fully trained to understand the complexity of this condition and respond appropriately. This to us is evidence of substandard care. This is from Betty Smith, the mother of Nathan. In Hammersmith, me and Caroline do a lot of teaching sessions, either be on the ward, new starters, colleagues, A&E. We try as much as possible to go to both sides of the A&E and try to do teaching session 3 to 6 monthly, just because of the staff turnover. Recently, last year, Kike and our social worker and Caroline went to Job Center Plus as well. I know it's outside, but we are preaching outside the hospital as well, just to create awareness of sickle cell as well. And as part of the enquiries as well, lots of patients and relatives, they do give their feedback on treating a sickle cell patient, inquiries into avoidable deaths and failure of care for sickle cell patient in secondary care. It should be shocking for a senior trained medical staff member to say that they never heard of sickle cell disorder, as it will be for them to say that they've never heard of cystic fibrosis or diabetics. And this is one of sickle cell patients as well, just stating how they feel when they present in A&E or when they come to the ward. Going to hospital as a sickle cell patient requires you to put on an armor, because from the moment you reach A&E, it becomes your job to convince everyone that you're really in that much pain and not simply there for medications. So, as I said, we'll keep going out there, preaching the gospel until things change.
Just to add on to that report, we just want to inform all the CNS here today that there's a new sickle cell competency booklet that's just been released recently, and also there's an e-learning website for all the nurses in Imperial College to just go there, empower yourself on what sickle cell is. And thank you very much for listening.
Sit down.
Thank you very much, Afo and Caroline. Open it up to questions or comments from the audience. I had one comment really, which is you've identified how during a crisis other potentially life-threatening complications may occur, or a crisis might occur in the context of potentially life-threatening complications such as sepsis, and why it's important for treatment to be instituted rapidly. One of the challenges we have is sometimes knowing if a patient who has sickle cell disease has been admitted under the care of another clinical specialty, as I think was the case you described, where a patient was receiving treatment for biliary complications but wasn't under the care of a specialist hematology team. What do you think we can do to try and ensure that when a patient with sickle cell comes into hospital, the specialist team or the local hematology team are alerted as quickly as possible?
So this is why we do the teaching sessions either via A&E or any other wards there, just to create awareness. We also do a teaching session on how to assess them, and when doing this session, we also give our numbers and the hematology registrar number, just in case if advice is needed as soon as possible. We always make sure that we let them know that patient need to be assessed and treatment need to be started within 30 minutes. Not more than 30 minutes, within 30 minutes.
Yeah, thank you. Any questions? Yes. Yeah. I think there's a microphone going to come around.
That's good.
Is it on? Hello? Oh gosh, it is. Hi. Is there like an awareness of sort of blood transfusions, blood donations, and is there more work that needs to be done to increase how much people are actually donating blood to support the transfusions for adults and sickle cell?
We do encourage patients and relatives to donate blood. As you are aware, most of our sickle patients are from ethnic minority group, and of course the people that donate blood are not from that group. Unfortunately, I can't donate because I need enough to live and I don't have enough to give, but I will encourage people to donate blood.
There is also a national campaign through NHSBT to try and recruit more donors from ethnic minority groups in order to ensure more units that are compatible with people with sickle cell and thalassemia are available.
Just in relation to your comment, Mark, about ways to help protect and support adults with sickle cell, in Imperial, do you have method by which you have alerts for those patients? So, you know, like where you have electronic notes, like we do in pediatrics, an alert comes up, if admitted, these are the actions that need to be done for conditions that are rare. And I don't know whether adult physicians actually look online on notes, so that's an issue there. And the other one is the people themselves carrying, you know, these alert cards that they give to the nurses who triage them. And, you know, that is directed from their consultant.
Yes, do you want to?
Yeah. Yes, at the moment, in all the A&Es in Imperial College, there's an alert there for all patients who attend A&E. There's a sickle cell alert. And also recently, we had a program where we upload their information in Universal Care Plan. There we put an alert to when the ambulance picks them up, they know that they are sickle patients. And they take them to their registered centers. So that way, they are treated immediately. Also, we give them, there's a card from the Sickle Cell Society that we give it to them when they come in outpatient clinic. And this card is for them to carry on them everywhere they go, because we understand that there are some trusts outside London, if they were traveling, that will not recognize sickle cell. So they carry these cards with them to present if they needed A&E assistance to say that they are sickle.
Does it say that they should contact their hematology team?
Yes, so if, for instance, a patient is registered in Imperial College, Hammersmith, we have a designated unit, the hyperacute units. We don't have an A&E, and we give all of them numbers to contact the unit if they were in crisis. So if they are traveling anywhere, they still have those contact details. If they get admitted outside of Imperial College, the hospitals will contact us. They have the CNS contact. They usually contact us to let us know that our patient is admitted in their trust.
And our patient also have their patient key records as well, because I understand that the UCP is only for London for now, so it's not yet outside London. So if they go to places like Brighton, for example, and have crisis, they have their patient key record, which we do and give to patient. This consists of their past medical history, medications they are on, if they're on exchange. And on the right-hand side, our numbers are there for the team there to contact us if they need advice as well. Yeah.
Just for the benefit of anyone from outside of London, the UCP, Universal Care Plan, is a digital platform which has recently adopted, along with a number of other medical conditions, sickle cell disease, and there is a project in progress at the moment to upload individual care plans for all sickle cell patients in London. I think we've got about 60 or 70% of our patients so far uploaded to the UCP. And the benefit of this will be that all NHS providers will be able to access that information across London, including the London Ambulance Service, and institute the patient's agreed care plan in an acute crisis setting as quickly as possible. Okay, Io.
You mentioned that, according to NICE standard, that every patient should be seen within 30 minutes of admission in E&E. I just want to ask, is there an indicator to measure this compliance with E&E staff? Because most patients that I've spoken to, they always say they spend 2 hours, 3 hours. So is there any indicator to measure this compliance?
Shall I answer that? Yeah, it's one of the specialist services quality indicators that we have to report as specialist haemoglobinopathy teams to NHS England. So it's a key metric that is being monitored nationally. We have encountered, as many services have, some difficulties in meeting that 30-minute target. So the target is the patient to receive their first dose of analgesia within 30 minutes of presentation. And in response to that, a working group, including some people here today, including Stephen Acutely, who will be talking later on today, have worked with our receiving unit, triage unit, to achieve a 96% compliance with that target. So it is something that is being monitored. It's more challenging, I think, to meet in the context of ED departments, but there's a lot of work being done there as well to try, as we've heard, to try and identify patients with sickle cell as soon as they attend ED, so they can be triaged quickly and receive treatment promptly.
Thank you. So I just wanted to add, it seems like we are all trying to meet the target of the 30 minutes. And I know that's really difficult, but what we're finding is that with the UCPs and, you know, with the ambulance being able to give medication on time, they give the initial medication, but what happens is that when they come into hospital, it's the second doses now that are being delayed. So I think when we're doing our teaching with CNSs and everything, you know, with A&E, it's important that once they've had their first dose, it's important to think about the second dose as well, because what you would do is you've undone the good work that the LES team have done. So it's important the first dose, 30 minutes, if that's great, but then the next dose, we need to kind of look at it. So I'm wondering maybe another audit or a metric that needs to be looked at is first to second dose and then second to third dose to see what that looks like.
Do you want to comment on that?
Just to add on that, I think that the difficulty here is staff retention in A&Es, as you know, and sometimes it's overwhelming. The waiting times, as you know, they are overwhelming. So sometimes you would imagine that the staff there should know immediately that this patient should receive their pain relief, but then if their workload doesn't permit them, it's not always the case, and it's difficult. Although we tell them time and again, we do the teachings, we make them understand what sickle is. They are really in pain and they need their analgesics on time. It is difficult because staff retention in EDs is not very good, as you know. And what is happening now is the patients are refusing to go to EDs. They prefer to come to RH Hammersmith, and when they call and there's no bed available, they'd rather stay home and manage. And this is very worrying because it could be something really severe. So going forward, we just have to keep trying to make sure that the ED staff are updated and as frequent as possible on the need to give their pain relief on time when they come there.
Okay, well, I